We left off our discussion on heart murmurs, and we had spoken about the majority of it already. We looked at a bunch of stuff last time involving the flow vectors of which way blood actually flows as it goes through any of the heart valves, and we also kind of looked at the different phonocardiograms and bedside maneuvers and how all of these things change the flow of blood to either intensify or soften any heart sound, right? We looked at what mitral valve prolapse looks like, hypertrophic cardiomyopathy looks like, all the different heart sounds. And right now we stopped last video at the heart murmurs. So looking at it now, there's a lot to be known, because sometimes you'll get one of these images like this, or you'll get a description of how a murmur might have changed based off of some bedside maneuver some child or adult might have done, right? And they'll definitely try to describe to you where they hear the sound, right? What's the location where the sound is the loudest, and if it's radiating anywhere, right? A lot of these things are often given to you. So heart murmurs, they're divided as systolic or diastolic, and then there's the continuous patent ductus arteriosus, which is there in systole and diastole non-stop, right? So these are the main ones, at least the systolic and diastolic. These are the first 6 that we have to talk about, and they're the main ones that can pop up. They're the only real murmurs that are even like popular in real life as well as on the exam. So first thing, we have aortic stenosis, right? The aortic valve may be calcified, so the left ventricle has to put out more pressure to pump against this stenotic valve. This decreases the stroke volume, and there will be a weak pulse. So there will be less blood in the aorta for coronary artery perfusion and for systemic flow, right? Because not much blood is going to go from the left ventricle into the aorta, because the aortic valve won't even open up that much. In addition, you will have left ventricular concentric hypertrophy. With lesser blood flow to the brain, there will also be syncope. Hypoperfusion of the coronary arteries in diastole with increased oxygen demand will lead to possible ischemic events and angina. Right? So anytime a person with aortic stenosis tries doing something like running or picking up heavy stuff or anything like even close to exercise, they're going to have chest pain. Dyspnea is going to be due to the increased left ventricular thickness, which leads to diastolic dysfunction, right? Because the hypertrophied heart is so thick that the ventricle itself becomes pretty tiny inside, so there isn't really much space for blood to go into it, right? And it becomes very non-compliant, right? The left ventricle is not going to be compliant to expand and fill in more blood into it, right? So you end up getting dyspnea. The aortic chemoreceptors sense a decrease in oxygen and tell the body to breathe more, right? Loudest in the second intercostal space on the right side, and can be radiating to the right carotid, right? So that's right here. They tell you it's a crescendo, decrescendo, systolic ejection murmur, and soft S2 ejection click may be present. The left ventricle has significantly higher pressure than the aortic pressure during systole, and it's loudest at the heart base. Radiates to the carotids. There's something known as pulsus parvis et tardus, right? Pulses are going to be weak with a delayed peak. Right? Your pulse is entirely based off of when your left ventricle contracts and a bunch of blood comes out, and then the blood goes to your arms and legs and everywhere, to your head. Right? You can feel it here. You can even feel it on your scalp when you're sleeping. If you have your hand under your pillow, you can actually feel the blood that's coming to your head, because you'll feel a pulse behind your head. Right? So pulses are going to be weaker now because stroke volume is weaker. Not much blood is actually being pumped out. So it can lead to syncope, angina, and dyspnea on exertion, right? They get tired really easily. Most commonly due to age-related calcification in older patients, or in younger patients, look for early onset calcification of a bicuspid aortic valve, right? So like Turner syndrome. And this is the phonocardiogram. So you can see the sound is crescendo, decrescendo. It increases, then it decreases. And this part here where the sound gets maximal is actually the part where the left ventricular pressure is highest, right? So we saw here in aortic stenosis, you can see the aortic pressure is much higher than the left ventricular pressure, which is the green line, is much higher than the aortic pressure. Right? That's because the left ventricle had to use a lot of pressure to even open the aortic valve. Right? And then the left ventricular pressure went all the way to 150 when it's normally supposed to go up to 120, and we talked about all that in the last video. So point B over here would be where the aortic stenosis murmur would be loudest, because that's where the left ventricular pressure is the highest. And S4, right? S4 may be heard due to decreased compliance of the hypertrophic myocardium. Restrictive cardiomyopathy also has S4 in it. Right? This entire time with your concentric hypertrophy, your heart is going to have diastolic dysfunction. It's not going to fill well. It's not going to be compliant to incoming blood, and that's when you hear S4. Right? Then the next one is mitral or tricuspid regurgitation, which are both holosystolic. Right? So throughout the whole of systole, from S1 to S2, that entire time when the ventricle is contracting, blood is going to be going backwards through whichever valve is messed up. Right? High-pitched blowing murmur. Mitral valve is going to have the loudest sound at the apex and radiates toward the axilla. Mitral regurgitation is often due to ischemic heart disease after an MI, or due to mitral valve prolapse, or because of left ventricular dilatation. Right? So ischemic heart disease, because oftentimes if you had like an MI, you can actually mess up the chordae tendineae that actually hold the valve, right? So if the chordae tendineae are not as strong as they're supposed to be, the valve starts regurgitating. Tricuspid is going to be loudest on the tricuspid area, right, which we saw right here. So this is where the tricuspid regurgitation is going to be loudest, right? And this is where mitral regurgitation is going to be loudest, right? And you can't really hear it anywhere else, because remember the way the heart is placed. We talked about it in the last video, that because of the way the heart is placed, the front of the heart is mostly your right ventricle and your right atrium. The back over there is your left atrium and left ventricle. And we looked at flow vectors, right? The way the blood moves. So you can see here, this one is your mitral valve. When blood is coming this way, it's going to be towards the apex, and you'll hear it loudly at 4A and 4B. Regurgitation goes backwards that way, but you can't hear anything backwards that way. So you're still going to hear it here, because this flap is going to keep moving back and forth. Right? So every time it moves forward, there's a loud sound that you're going to hear over here throughout all of systole. Right? And that's what a regurgitating valve is going to do. It also radiates towards the axilla, which is the backwards radiation that we're talking about, right? That you're not going to be able to see, because your left ventricle is towards the back, your left atrium is towards your esophagus. So there is a radiation in this direction that kind of ends up going to your axilla. The way they're showing this happening over here as well. All right. So mitral regurgitation and mitral stenosis, they both kind of are heard in about the same area. And for people who would get it, so rheumatic fever and infective endocarditis can cause either mitral regurgitation or tricuspid regurgitation. Right? Either one of those issues. Rheumatic fever is usually going to be related to mitral regurgitation. Infective endocarditis in like IV drug users will usually lead to tricuspid regurgitation, because IV drugs, anything you inject into yourself, the blood that you injected it into comes back to the right heart, right? So that's going to affect the tricuspid valve. The way to differentiate mitral versus tricuspid regurgitation, besides the fact that, you know, whatever they tell you in the question stem, you got to look at that. There's one thing about inspiration, right? Only tricuspid regurgitation increases with, I wrote respiration here, but it should really say inspiration. Right? It increases with inspiration, because when you breathe in, you bring back more blood to the right heart. So that's going to be more blood to go through the tricuspid valve, and that's going to cause more sound. Whereas on the left side, it doesn't really change with inspiration. The mitral regurgitation does not change with inspiration or anything. An audible S3 indicates a severe mitral regurgitation, right? And S3 is often the sign of both severe mitral regurgitation as well as heart failure. The S3 is a result of increased left ventricular filling due to a large volume of regurgitant flow. Right? Remember that if you have mitral regurgitation, then when your left ventricle contracts, a lot of blood gets sent back to the left atrium, and then after that, when diastole is going to come, there's going to be blood that returned from the left ventricle, as well as fresh blood coming into the left atrium. So you have more blood in your left atrium than normally should be there. Right, so that's too much filling. A lot of blood is coming from the left atrium to the left ventricle, which is what can also lead to left ventricular dilatation. Right, so it all becomes pretty problematic. That's mitral and tricuspid. Then you have mitral valve prolapse, right, which we saw the image of right here, right? So in mitral valve prolapse, your mitral valve itself kind of bends like this, right? Every time your left ventricle contracts, it bends like this, and blood, slams into these little curves over here, and a little bit even goes backwards. So when that slamming happens, that is what causes the mid-systolic click. Right, that's the MC right here, mid-systolic click. So you're going to hear three sounds. You won't just hear a lub-dub, but you'll hear a lub, which is S1, then you hear some kind of click, and then you hear a murmur, and then eventually, immediately after that, you hear a dub. Now remember, keep in mind that this entire S1, S2 phase over here happens within like 0.1 second, So you really have to listen to it a lot of times to get comfortable at hearing it. You can go ahead and YouTube it. Right, listening to murmurs, the best way to do it is just searching for it on YouTube. And if you search for mitral valve prolapse murmurs, you'll hear the mid-systolic click very clearly. Right, do not get confused where it can really start sounding like S1, S2, and then a diastolic murmur. Right, it's the same thing when you're listening to it. It all sounds the same. So when you're listening to it, it can actually sound like you heard S1, then you heard S2, then you heard a diastolic murmur. And it's not going to be a diastolic murmur, right? Because diastolic murmurs, there's only two you really have to worry about, right? Aortic regurgitation or mitral stenosis. And for both of those, the story, the whole question stem should be very different than whatever stem you would get from mitral valve prolapse. So this is going to be a late systolic crescendo murmur with the mid-systolic click due to sudden tensing of the chordae tendineae, right? You see these strings that suddenly get tensed. That's what made the sound. And your mitral valve is all bent and stuff, filling up with blood in there. Most frequent valvular lesion. Best heard over the apex, loudest just before S2, usually benign, can predispose to infective endocarditis. Can be caused by myxomatous degeneration, primary or secondary to connective tissue disease such as Marfan or Ehlers-Danlos syndrome, rheumatic fever, and chordae rupture. Right, so you really have to look for whether or not they're telling you like if there's any kind of stuff stuck inside, right, on the under surface of the mitral valve, if there's anything stuck on the upper surface of the mitral valve. Either way, this is going to be functional for the most part, but remember the mitral valve is the one valve that gets injured the most in like normal average humans as it is. And if you have mitral valve prolapse, it's at even a higher risk of getting injured. Right? And then if you get an MI and these chordae tendineae stop working so well, your mitral valve might not even work. And if you don't have a mitral valve, that's pretty problematic. You can actually end up getting an AFib because things between the left atrium and left ventricle wouldn't be working too well. The last systolic murmur is a VSD. Remember that if you have a VSD, which is the most common later onset cyanosis heart defect, if you have a VSD, this is going to lead to things going from the left ventricle into the right ventricle, right? Because normally it's already pretty hard to send blood from the left ventricle into the aorta because of the high afterload. Now with an opening, you can just send blood from the left ventricle into the right ventricle, right? And that's going to be the easier path for the blood to go into. And that's going to suck for the person because the left ventricle has highly oxygenated fresh blood that needs to go to the brain and the limbs. It won't be doing that anymore. You'll just be circulating oxygenated blood with deoxygenated blood from the right ventricle, all just going back into your lungs over and over. Right? So VSDs are pretty problematic for that aspect, and they're going to be holosystolic as well. Right? Very similar to mitral and tricuspid regurgitation. Holosystolic, the whole time your left ventricle is contracting, it's going to send blood through the VSD into your right ventricle. And this is going to be loudest at the tricuspid area. We talked about this last time because your heart is kind of tilted in this manner so that the left ventricle is in the back and the right ventricle is in the front. So blood is actually going through the VSD in this direction in terms of like a flow vector. So it's coming straight out this way, and you're going to hear it by the same spot you would hear any tricuspid sounds, right? And for an ASD, it's just going to be a little higher. You would hear it where the aortic sounds are not aortic, pulmonic sounds usually are at, right? So you still hear both ASDs and VSDs though on the left sternal border because they're both shooting blood towards the front, since they're both shooting blood into the right heart from the left heart. Right, so that's really all there is. Differentiate from mitral or tricuspid regurgitation by the lack of left ventricular or right ventricular dilatation, respectively, and patient history as well, right? Loudest at tricuspid area because flow vector is from the left ventricle to the right ventricle, as I just described right now. This actually it needs to be fixed up very quickly, because if you don't, later on we're going to see something called Epstein's anomaly, where to fix this, right, why is blood going from the left ventricle to the right ventricle? That's because it's easier, right? There's lower pressures in the right ventricle, lower pressures at the pulmonic valve as opposed to the aortic valve. So to fix this, your pulmonic valve ends up becoming a higher pressure valve than your aortic valve. So now blood actually goes from the right ventricle to the left ventricle, right? It reverses itself, and now all your left ventricular blood will correctly go into the aorta. The only issue with this is that your pulmonic valve is not supposed to have that much pressure there, and that's going to lead to pulmonary hypertension, right? Which is pretty much fatal. So Epstein's anomaly is something that can happen if you don't fix up a VSD, and we're going to see that later on. What we're looking at now are your diastolic ones. The diastolic ones, when I was studying at first, I made up this thing called D-arms, right? D-arms for like dining arms, and the ARMS remind me of aortic regurgitation and mitral stenosis. Now, of course, the other diastolic murmurs are the opposite of aortic, so pulmonic regurgitation, and the opposite of mitral, which would be your tricuspid stenosis. But those two issues, pulmonic regurgitation and tricuspid stenosis, are very rare, like in real life. They just don't happen that much. It's not a very common thing to see tricuspid stenosis or to see pulmonic regurgitation. Those aren't actual things that happen, and I've really never seen them in a question either. But if anything, you do need to associate it with the same kind of issue as these guys. So what happens in the aortic regurgitation? So right after S2, right, because these are diastolic, so you're going to hear both of these after S2. Right after S2, you hear a sound, a murmur that dies out. Right, you see how the sound is dying out? So it's a high-pitched, blowing, early diastolic decrescendo murmur. The sound is dying out. Long diastolic murmur, hyperdynamic pulse, and head bobbing when severe and chronic. Wide pulse pressure, often due to aortic root dilation, bicuspid aortic valve, such as in Turner syndrome, endocarditis, or rheumatic fever. And this progresses to left heart failure. Right? If it's due to aortic root dilation, then the murmur is best heard at the right sternal border. Otherwise, it's heard at the left sternal border. Now, what you need to know is this little part they put wide pulse pressure. Right? Wide pulse pressure. Remember from the beginning of physiology over here that pulse pressure is directly related to stroke volume. When you have aortic regurgitation, blood is going to come back into the left ventricle, and you're going to have more blood in your left ventricle than you were supposed to have. So now you're adding blood into the left ventricle from both your aorta as well as your left atrium. So that's more blood in your left ventricle, right? So that's a higher stroke volume, which means you're going to have a higher pulse pressure. The other thing is, when we looked at our cardiac cycle images, aortic regurgitation, you can see that the valve opens at about a pressure of 50 when it normally should open at about 80, and it goes all the way up to 150 with the left ventricle, right? They're going up together, all the way up there, right? Because your aorta is very, very compliant. It's pretty much open. It's a regurgitating, non-stiff valve. And this difference from 50 to 150, that is your widened pulse pressure, when it should normally be 120 over 80 and have a pulse pressure of about like 40 or something, right? So that's what you have to watch out for. That can be given to you in a question. This thing I put here, let me make it a little bigger for you guys. This thing here is called a water hammer pulse, right? The normal pulse should look like that. This is a water hammer pulse. This is something that Amboss talks about quite a bit, right? The water hammer pulse. So I have a note on that at the bottom right here. Aortic regurgitation. So this starts as soon as the aortic valve closes at S2 and is decrescendo. Heard best in the third intercostal area on the left, not in the aortic area, right? Because aortic area is up here, right? And that's for aortic stenosis, when blood goes this way. Aortic regurgitation, blood is going back this way, backwards, so you're going to hear it on the left side. Because the flow vector is backwards towards the left ventricle. Inability of the aortic valve leaflets to close during diastole leads to regurgitation into the left ventricle with an increase in left ventricular and diastolic volume. Right? During diastole, the left ventricle is being filled by the left atrium, but at the same time, a lot of blood is going to be coming back from the aorta. This results in chamber enlargement and eccentric hypertrophy, increasing the stroke volume and systolic pressure. But there is a decreased diastolic blood pressure, so patients have a widened pulse pressure. The pulses are extremely strong as well, which is why you're going to have this hyperdynamic pulse and what do they say? Non-diastolic murmur, head bobbing, right? Hyperdynamic pulse and head bobbing. And so literally, as the blood is like regurgitating backwards, your head is also going to be bobbing every time blood is going down the aortic valve back into the left ventricle. And that's something that can be described in the question. Aortic stenosis is the opposite, with the weak pulse and the lower stroke volume. Amboss further teaches of a water hammer pulse, which occurs due to the rapid injection of a large stroke volume into low pressure arterial system. Right, so that's what the water hammer pulse is about. You can see that right here. Right, so this is what I would say kind of looks like shark fins, right? So the shark fins are all about the water hammer pulse. And a water hammer, what they're talking about in terms of water hammer is, if you look it up online, what they describe it as is like going like this. So this is what's called water hammering. That's apparently a thing. I don't know. They describe it as doing that. So that's what a water hammer pulse is, and that's apparently what's happening with the blood, because it's going through the aorta, but then it's slamming back to the aortic valve and coming through it as well. And that's a hammering that apparently shouldn't happen, and it's not a normal thing. I've never seen it being mentioned until Amboss, so you know how significant it is up to you. But aortic regurgitation has a weird, powerful pulse, so just remember that. Right, very powerful pulse, so powerful that it even causes head bobbing. The last diastolic one is mitral stenosis, right, which is synonymous with tricuspid stenosis. Follows opening snap due to abrupt halt in leaflet motion in diastole after rapid opening due to diffusion at the leaflet tips, right? So there's something known as an opening snap. Basically, you're going to hear this S1 sound, you're going to hear the S2 sound, and then right after that, you're going to hear another sound, and then a continuous low sound murmur, right? This is a very low sound murmur. It doesn't go as high as these waves are, right? It doesn't go that high, pretty low. Delayed rumbling, mid to late diastolic murmur. Left atrial pressure is much higher than left ventricular pressure during diastole. And we see that. We see that in the curves we looked at last time. So if we go back to mitral stenosis right here, so you see left atrial pressure is very high, higher than the left ventricular pressure is right here. And this phase right here is diastole, right, where your left ventricle has no pressure in there, it's just filling. So during diastole, you can see the mitral valve opened over here, right, and now you're doing diastole, you're filling up your left ventricle. Your left atrial pressure is much higher than the left ventricular pressure, and that shouldn't happen. So when that happens, that's a sign of mitral stenosis. A decrease in the interval between S2 and the opening snap correlates with increased severity, and that's something that gets tested. UWorld asks about it, Amboss asks about it, and it can easily be on your NVMe or your step 1. So basically, if the S2 and opening snap occur closer together, then your mitral stenosis is starting to get really, really bad, right? As opposed to if this occurs further away, then your mitral stenosis isn't that bad. Often a late and highly specific sequela of rheumatic fever. Chronic mitral stenosis can result in left atrial dilatation, which can present with dysphagia and hoarseness because of the compression of the esophagus or the left laryngeal nerve, respectively. Right? So the opening snap occurs due to the abrupt tensing of the valve leaflets as the mitral valve reaches its maximum diameter during forceful opening. As mitral stenosis worsens, left atrial pressure is increased due to impaired movement of blood into the left ventricle, and the S2 to opening snap interval becomes shorter. Right, so definitely remember that. Remember with rheumatic heart disease, which we kind of looked at already, but we're going to see a lot more when we get to pathology, that in the beginning you could have mitral regurgitation, and then later on it can become mitral stenosis. Right? So it's a late sequela, right? A late sequela. It doesn't occur in the beginning. The first thing that occurs is usually mitral regurgitation. Right? Then the last thing, your patent ductus arteriosus, which I have a picture of right here. So you make it bigger. So you can see in infancy, during fetal life, this was necessary. Right? This thing was necessary because you didn't really have lungs. So when blood came, right, blood would come up from here, It would go through the patent foramen ovale. Well, it wasn't patent at that time. It would go through the foramen ovale, and then it would go up this way, supply your head and stuff. And this pathway here was necessary for blood to come back. Right? It was necessary for blood to come back, and then you would send it back to your IVC, and just blood would go back to the placenta again. After being born, this was no longer necessary. You did not need the patent ductus arteriosus. Ductus arteriosus was only there to bypass stuff, and now after being born, you don't need it anymore. If it stays there, then you hear a murmur throughout the whole systole and diastole. Right? So during systole, when your left ventricle contracts, it's going to send blood into the aorta. You're going to hear a murmur because blood is going to come into here instead of going into the descending aorta. A lot of it will also come into here and go back into your pulmonary vessels. And then during diastole, when some blood was supposed to go backwards down into the aorta again to supply your coronary arteries, it'll again go back into here instead. Right? So the whole time, a lot of blood is just going to keep going into your ductus arteriosus pathway, going into both of your lungs. Right? You're going to be sending a lot of oxygenated blood into your lungs for no reason whatsoever. So you hear a continuous machine-like murmur, where you'll never describe anything else as a machine-like murmur. Best heard at the left infraclavicular area, right? Because that's exactly where your ductus arteriosus is. So you're going to hear it at the upper area up here somewhere. Loudest at S2, right? You can see it's increasing in volume, then it starts decreasing in volume. Often due to congenital rubella or prematurity, right? In rubella, as we saw in microbiology, rubella kind of messes up a lot of the smooth muscle in its actual development. So the smooth muscle development won't work too well over here, and you won't make what you're supposed to make to close off that ductus arteriosus. And in prematurity, you're just born too early. You didn't fix things up the way you were supposed to, and that's really all that really happens there. So you have an open tube between the aorta and the pulmonary artery. Blood gushes into the pulmonary arteries and to the lungs. So blood goes to the pulmonic valve direction. Hence, you hear it best in the pulmonic area, which is in the left infraclavicular area. Right? So pulmonic sounds are going to be louder, but it has nothing to do with the pulmonic valve. Let me see. When the mitral tricuspid valve closes at S2, some blood continues to flow from the ascending aorta into the pulmonary arteries for a little bit, and that's kind of how this sound is just going to be. Again, I would highly recommend, listening to this continuous machine-like murmur. You're going to loudly hear S1 and S2, but there's going to be a murmur before S2 and after S2, and that only occurs with the patent ductus arteriosus. None of the others have a murmur on both sides of S2. That's quite a giveaway of a scenario. Also keep in mind that this is also another spot they love bringing up embryology. Right? So you can see I made a note here. Remember that the ductus arteriosum is a remnant of the 6th aortic arch, right, from embryology, which we're going to see much later on under reproductive. So just important to make those connections. Always keep making connections, because the more times you make them, the better it's going to be for you to just have that recall. Alright, a lot easier. So now on the next page, I have a couple of practice questions. We looked at this auscultation of murmurs last time. We talked about all the different things. So this diagram has already been discussed in the last video, where I also mentioned that first aid doesn't have passive leg raise, but you didn't need to know passive leg raise. All you need to understand with every maneuver is, does it affect preload or afterload, and how does it affect it? Does it increase preload? Does it increase afterload, or does it decrease them? Based off of that, you should know what's happening with the various heart sounds. Now, so that's done. Let's take a look at some of these questions, right? So some of these questions are related to the two phonograms we see up here, and these are great ways to tackle what we've been talking about so far. So the first question we have: 11-year-old boy is brought to the office for a routine checkup prior to enrollment at summer camp. He and his mother have no health concerns. Family history is significant for his father passing away suddenly from a heart condition 2 years ago. He is in the 75th and 80th percentiles for height and weight respectively. Vital signs are normal. Physical exam shows a well-appearing child. His lung is cleared auscultation. Cardiac auscultation findings at the lower left sternal border are provided in the media exhibit. His auscultatory abnormality intensifies with the hand grip exercise. What is the most likely to be present in him? And in the question, they give you this image, but it's not labeled a VSD. They just give you this image. So what you're basically seeing is a holosystolic murmur From S1 to S2, it's there the whole time. And there's only 3 guys that do that, right? Mitral regurgitation, tricuspid regurgitation, or a VSD. And now you're sitting there wondering, what could this 11-year-old boy have? Well, they gave you a maneuver that pretty much gave away the answer. Hand grip made the sound louder, right? So when you do hand grip, remember that in a VSD, blood goes from the left ventricle to the right ventricle because it's really hard or harder to send blood from the left ventricle into the aorta, right? Because there's a high afterload above the aortic valve. If you do hand grip and you further increase afterload because flexing increases your blood pressure and it makes it harder to open your aortic valve, then even more blood will go through the VSD from the left ventricle to the right ventricle, making that sound louder. So the answer was a VSD. This was actually a very easy question, and only 39% of people got it right, after which 30% chose hypertrophic cardiomyopathy as well. Right? A trick question that for some reason these guys fell for, although there was really no reason to think that an 11-year-old boy who's got everything perfectly fine would have hypertrophic cardiomyopathy. Right? Yeah, I understand that his father suddenly passing away from a heart condition 2 years ago could make you think that the child might have inherited the hypertrophic obstructive cardiomyopathy, which is a autosomal dominant kind of thing. But that really wasn't, shown here. And furthermore, you can see from this table that when you do hand grip, right? Yeah, the murmur decreases for hypertrophic cardiomyopathy. Right? Hand grip decreases the murmur for hypertrophic cardiomyopathy, which would be the opposite of what we see here. So it couldn't have been hypertrophic cardiomyopathy. Alright, so the presentation of a VSD depends on its size. Large defects result in high volume shunting of blood across the VSD, causing a low interventricular pressure gradient and a soft or absent murmur. In contrast, small defects allow only a small amount of blood to flow across the VSD, and most patients are asymptomatic and have loud murmurs that are detected incidentally on auscultation. Right? Because if you're sending a lot of blood through a smaller defect, it's going to make a louder sound because you're really trying to push it through there. So that gets heard, but it's going to be asymptomatic because it's a very tiny defect. Not much of the blood is going to go through there. In this asymptomatic patient, a harsh holosystolic murmur heard at the mid to lower left sternal border is indicative of blood flow through a small, hemodynamically insignificant VSD. The hand grip maneuver increases systemic vascular resistance or afterload. This impedance of forward flow of blood causes flow from left to right across the VSD, resulting in murmur accentuation. And then my own explanation I just gave to you guys. So that was it for this question. Let's look at the next one. We have now a 5-year-old boy, so they're just getting younger. Well, after that it's going to be a 74-year-old, so that's going to be something. A 5-year-old boy is brought to the office by his parents for evaluation of cyanosis with minimal exertion. He has had occasional episodes of turning blue that first began during infancy and are now occurring more frequently. During the episodes, the boy assumes a squatting position as it makes him feel better. Right? And this is very common. This actually is given in questions almost all the time. I can confidently say there's an extremely high chance it'll be on your step 1 as well. The family recently immigrated to the US, so the boy has never had a medical checkup prior to his visit. Physical exam reveals a prominent right ventricular impulse and a harsh systolic murmur. What embryological event is the most likely mechanism that caused his condition? And the answer was deviation of the infundibular septum. 42% of the people got it right. 34% chose endocardial cushion defect, which is related to a whole different thing. This patient's presentation of cyanotic spells that improve with squatting, prominent right ventricular impulse, and a systolic murmur is all consistent with tetralogy of Fallot. And this is what you get. This is exactly how you get in terms of like a question scenario for tetralogy of Fallot. Abnormal neural crest cell migration leads to anterior encephalad deviation of the infundibular septum, resulting in a malaligned VSD and an overriding aorta. Right? Things move in weird ways, and some things come to the front, the wrong things go to the back of the heart, and everything gets messed up. Cyanosis occurs due to right to left shunt from the right ventricular outflow tract obstruction. Right? One of the biggest deals for tetralogy of Fallot. Squatting increases afterload and decreases this right to left shunt, improving the cyanosis. Right? Any right to left shunt will always become left to right if you increase afterload, and squatting does that. Endocardial cushion defects are related to the AV valves, and that's usually going to be something for Down syndrome, which is not what this boy had. Alright? So this is how you get a question on tetralogy flow, and you have to remember that. The next one, 74-year-old man comes to the office for a follow-up visit for hypertension. His last visit was a year ago. He has no chest pain, shortness of breath, leg swelling, or dizziness. He is compliant with his medications and can tolerate a moderate level of physical activity. Blood pressure is 145 over 75. So you can see the 75 is fine, right? But the 145, there's a higher systolic blood pressure. So always look at the two numbers individually and figure out where the issue is. The issue is something systolic here. Pulse is 67 and regular. 67 is approaching 60, so it's about to become pretty low. Auscultation findings at the base of the heart are depicted with an exhibit below of aortic stenosis. Right? So they gave this image, but it wasn't labeled. This is the image they give you. So when you see such an image, you see the diamond shape, you can see it's crescendo, decrescendo, and that should ring a bell for aortic stenosis, as should his age, right? A 74-year-old man coming in for any kind of cardiac question on step 1, you're going to think aortic stenosis and then try to rule out other things. What is the most likely cause of his physical findings? And the answer is very easy, valvular calcification, right? Because he's 74. The diagram depicts a crescendo, decrescendo systolic murmur, peaking in mid-systole, characteristic of aortic or pulmonic stenosis. The most common cause of aortic stenosis in elderly patients is degenerative calcification of the aortic valve leaflets. Right? And then that's literally going to be all you have to be able to explain. This next question is really interesting. This one was pretty cool. This is coming from URL 2. So a 68-year-old man comes to the office due to exertional shortness of breath and fatigue, which have progressed over the past year. The patient has a history of hypertension, but medical history is otherwise unremarkable. He is a lifetime non-smoker. His father died of a heart attack at age 70. Blood pressure is 144 over 74. Pulse is 72 and regular. Cardiac auscultation reveals a 3 out of 6 ejection type late peaking systolic murmur and a barely audible S2. The murmur diminishes in intensity during the straining phase of the Valsalva maneuver. What process underlies his condition? So before you even figure out what process, you really got to figure out what happened to him. So being the way this question is described, he's 68, so he's pretty old. He has hypertension. And then they tell you that the S2 is barely audible, which means that the aortic valve closing is barely audible. And the reason it's barely audible in this guy with a systolic murmur is because he most likely also has aortic stenosis, right? The murmur of S2 is lighter because the valve barely opens, so it just closes very easily without making much noise. And this question, you could see everyone pretty much fucked up. Right? 35% of the people actually got it wrong, and they picked an answer that seems very, plausible. Myxomatous valve thickening and elastin fragmentation, except that would be for something related to the mitral valve, right? This guy doesn't have a mitral valve issue. Cardiomyocyte hypertrophy and disarray causing asymmetric septal thickening. Very plausible answer choice. 27% of people got it wrong by picking that. And the right answer was differentiation of valve fibroblasts into osteoblast-like cells. Something I had never really heard of, didn't really know about at all. And this would definitely be a very unfair and hard question to give. So this patient's soft S2 and late peaking systolic ejection murmur that decreases in intensity with maneuvers that decrease left ventricular blood volume, like standing or Valsalva straining, are consistent with aortic stenosis, which most commonly occurs due to age-related calcific aortic valve disease. Right? The straining phase diminished the murmur because there was lesser blood to even go through. Right? Remember with the Valsalva and standing up, they both decrease your preload. So there's lesser blood going through the valve, so the sound always decreases for all the murmurs. All the valvular murmurs decrease in sound with standing up in Valsalva. So early CAVD is analogous to arterial atherosclerosis. The endothelium lining the aortic side of the AV cusps is exposed to the same high pressure and turbulent blood flow as the aortic vascular endothelium. As occurs with atheroma development in the vascular endothelium, these mechanical forces, along with smoking, hyperglycemia, and hyperlipidemia, which could be possible issues that people can have. He was not a smoker, but anyone else could have had. Over time, cause damage to the aortic valve cusp endothelium, triggering endothelial dysfunction and onset of a similar atherosclerotic process. And this connection to atherosclerosis is really big. Right? This is a newer type of question for UWorld, It's definitely very much of a test question because not many people are getting it right, but it teaches so much. And atherosclerosis is one of the top high yield things that are going to be on your step 1. You have to know it. And this connection of calcific aortic valvular disease is very significant, right? Aortic valve and atherosclerosis are both high yield, and they're teaching a new pathophysiology over here about how that calcification of the aortic valve is very similar to atherosclerosis in any other artery. So what happens now after this atherosclerotic process? There is subendothelial lipid deposition and infiltration of inflammatory cells like macrophages and T cells, followed by the release of inflammatory mediators like interleukin-1 and TGF-beta. Subsequently, there's increased production of osteopontin, proteins involved in tissue calcification. Right, so osteopontin is another new thing that they taught about in this question. I had never really heard about it before that. Fibroblasts differentiate into osteoblast-like cells, which is your answer here, leading to aberrant bone matrix deposition with progressive valvular calcification. Choice A, which 27% of people chose, occurs in hypertrophic cardiomyopathy, right? The hypertrophy and disarray, and that had nothing to do with this 68-year-old man. Right? Murmur increases with maneuvers that reduce left ventricular blood volume. Remember, Valsalva and standing up made hypertrophic cardiomyopathy have a decreased sound, because in both of those things, with Valsalva and your standing up, you have lesser blood, so the sound of hypertrophic cardiomyopathy would not be that bad. Would be increased. What am I saying? We just did the one place it decreases. The one place it decreases was with this question right here. We talked about squatting, right? And we said that hypertrophic cardiomyopathy was the wrong answer. Squatting increases the pressures, makes the volume lower for both mitral valve prolapse and hypertrophic cardiomyopathy. Murmur decreases. But anytime you do Valsalva or standing, that actually makes only this go louder. Everything else decreases. Valsalva and standing are only important for your mitral valve prolapse and hypertrophic cardiomyopathy. Remember that. Very important little fact to keep in mind, because this auscultation thing is always given. Valsalva is such a high yield thing. Abrupt standing, not so much, but Valsalva is extremely important. They love throwing that maneuver in there. Valsalva only increases the murmur for your HCM. Don't even worry about mitral valve prolapse, but if you want to, remember all of that. Because when you have decreased preload and you have lesser blood, right, with lesser blood, all the valvular murmurs don't make much noise with lesser blood because there's no blood going through the valvular murmur. But your hypertrophic cardiomyopathy, which is just a bunch of muscle in your heart, they start smashing into each other a lot more when there's lesser blood to keep the muscle expanded out. So you would have seen that, but that didn't happen in this question at all. Right? In this guy, the murmur diminished when he did the straining phase of Valsalva maneuver. In hypertrophic cardiomyopathy, though, Valsalva would have made the murmur louder. So this murmur information over here with the maneuver would have helped you knock out answer choice A, and you wouldn't be one of those 27% of people. Right? Choice C, which 35% of people chose, occurs in mitral valve prolapse. Right? We talked about a little earlier the myxomatous degeneration that can occur, and you can have things stuck to your mitral valve because of MVP. That didn't happen. And of course, again, the same maneuver, right? Valsalva maneuver, they told you intensifies it, but both MVP and HCM, both of those murmurs, right, they become, murmur diminishes, right? It diminishes, but both of those murmurs would increase with doing Valsalva or standing up, right? Because you would have decreased blood. So the MVP, remember with your mitral valve prolapse, if you have a lot of blood, you keep the valves pulled apart and they stay flat. If you don't have a lot of blood, because you're doing standing up or Valsalva, then the valves come closer and they start bending in like this. Right? But this guy's murmur diminished. So if it diminished from Valsalva, it cannot be hypertrophic cardiomyopathy and it cannot be mitral valve prolapse. So you automatically knock out A and C, and then you're just left with B, D, and E. And D and E really don't make any sense for what this person is going through. So even though B might not make much sense to you and you've never heard of this kind of pathophysiology, you just pick it. Right? And that was it. That's all you had to worry about there. So really make sure you know the maneuvers by heart extremely well. It says that even if you make a confusion, you could fix it yourself. Right? You can remember all of them as much as you want, but Valsalva and standing are the easiest ones. Because Valsalva and standing both decrease the amount of blood in the heart, all valvular murmurs are going to become soft. They're not going to make any noise because there's no blood going through them. Mitral valve prolapse and hypertrophic cardiomyopathy become louder because there's no blood in your heart. So the mitral valve, as I just said, they're going to come closer together and they're going to keep prolapsing and bending. And in hypertrophic cardiomyopathy, all the muscle just keeps smashing into each other because there's no blood in there. Right? So those become louder, nothing else. Otherwise, inspiration just brings blood to your right heart, so tricuspid and pulmonic sounds get louder. Squatting and hand grip, which both basically count as flexing and increasing blood pressure, increasing afterload, they make the sounds of almost all your valvular murmurs louder. Right? All your valvular murmurs become louder because there's going to be blood going through stuff that it was hard to go through as it was already, and that's going to make more noise. And if it's a regurgitating murmur, then more blood will go regurgitating backwards because they can't go forward flow due to increased afterload. Right? So very easy to get all of that down. The last question I have here is another U-Roll one. Pretty nice topic for this question. They tell you a 56-year-old man comes to the emergency department due to progressively worsening dyspnea. He can walk only a few blocks before becoming short of breath. He also finds it difficult to sleep lying flat and requires 3 pillows to prop himself upright when sleeping. Right, so these are all signs of heart failure. The patient does not use tobacco or alcohol or illicit drugs. His other medical problems include chronic hypertension. But he takes medications only when experiencing headaches, which is not the way blood pressure medications work, so he's not taking it correctly. Because of that, blood pressure is 170 over 100, and pulse is 80 per minute. Physical exam shows bilateral basilar lung crackles, JVD, and bilateral lower extremity edema because he has congestive heart failure. And it hasn't compensated yet. So this is decompensated congestive heart failure right now. A chest x-ray reveals cardiomegaly and hilar prominence. An ECG shows left ventricular hypertrophy. All of these are normal things you would see in a person with decompensated heart failure. An echo shows pulmonary arterial hypertension. Which of the following is the most likely underlying mechanism for this patient's pulmonary hypertension? Right? And then there's 5 answers, of which most people got it correct. A and B were pretty popular too, and then that's it. So A is hypoxia-induced pulmonary vasoconstriction, B is increased pulmonary artery flow volume, and the correct answer is F, vasoconstriction due to pulmonary venous congestion. Right, which is the correct answer for this guy with heart failure, and they tell you all the things that are happening. He's also getting a lot of issues in his lung. This is all signs of heart failure in the left heart, which is going back into your lungs, and then eventually is going to lead to right heart failure as well. So this patient has left-sided heart failure because you can see the orthopnea and the lung crackles, most likely due to long-standing poorly controlled hypertension. Hypertensive heart disease is the most common cause of left ventricular diastolic dysfunction, characterized by concentric left ventricular hypertrophy and decreased left ventricular diastolic compliance. Right? There's no space in the left ventricle to put blood into it anymore because of the hypertrophy, making the left ventricle very, very tiny. Right? It's all muscle in there now. It's characterized by concentric left ventricular hypertrophy and decreased left ventricular diastolic compliance. As a result, higher diastolic filling pressures are needed to maintain stroke volume and cardiac output. This increase in pressure gets transmitted backwards to the left atrium and the pulmonary veins, where it can cause pulmonary hypertension and subsequent right-sided heart failure. And you can see right-sided heart failure in this guy as well because he has the JVD and the peripheral edema. The pathogenesis of pulmonary hypertension due to left heart disease begins with a passive increase in pulmonary capillary and arterial pressure secondary to pulmonary venous congestion, which is the answer choice F. The high pressure results in endothelial damage and capillary leak of serum proteins into the interstitium. This leads to decreased production of nitric oxide, which is a vasodilator, and increased production of endothelin, which is a vasoconstrictor. And endothelin is the guy that causes the increased vascular tone and pulmonary hypertension. Over time, remodeling of the pulmonary vasculature occurs with more smooth muscle proliferation and collagen and elastase deposition. Remodeling is less extensive than in the idiopathic pulmonary arterial hypertension. So pulmonary hypertension due to left heart disease is usually at least partially reversible once you fix the main issue, where his main issue is basically his blood pressure. Right? In idiopathic pulmonary hypertension, there's just endless endothelin that causes a lot of pulmonary hypertension, and it's not reversible. Very much of it is just permanent, and you can save the person. You could give them symptomatic relief until eventually things get a little better, but the pulmonary hypertension won't really get lower. You'll have to give the medications that increase nitric oxide or something so that the pulmonary vessels stay dilated and the person can breathe correctly. Right, so those are all the practice questions related to the stuff we just talked about up to now from cardiovascular physiology. The next big topic is your myocardial action potential as well as your electrocardiogram. Right, the myocardial action potential is huge. We have your left ventricular stuff from the SA basically, and then your pacemaker action potential, right, which is mostly SA. Sorry, what am I saying? Not SA. This stuff here is your left ventricular stuff, right, which is all about the depolarization of your left ventricles, so the ECG stuff. And here is your SA and AV node, the pacemaker action potential. Two different action potentials that you really have to master, know very well, know the labels, know what ions are moving back and forth through each one of the phases, right? And I have other images that kind of really help you master the ions and keep in mind perfectly what ion is moving, because you will get questions on it. We'll do some practice questions on that as well. And then the ECG, which you have to perfectly master. We've been looking at ECG stuff from the beginning, where way in the beginning of our lectures for cardiology, I showed an ECG image right here. And I asked anybody that they find this picture or take a screenshot right here by pausing and master this, right? Because this image alone helps you know exactly what you're looking for on an ECG. And when you see something irregular in those places, you know what artery is involved, what part of the heart is involved. And 2-3 AVF was the most significant thing because that's related to the right coronary artery, which actually gives blood to your AV node. So that's pretty significant, right? Know it very well. ECG localization is extremely important, and you do have to practice looking at real ECGs as much as you can. So we'll get to that. We'll look at some real ECGs as well and some practice questions I have here. And it breaks into a couple more ECG related pathologies, and that'll be pretty much the end of all of that stuff. So I'm going to continue from there in the next video to really master ECG stuff. Alright, thank you very much for joining right now, and see you guys again later on.